All right, we're going to get started. Welcome, everyone. I'm glad to see so many of you in person and those who are joining over Zoom. Welcome. Today, we continue the Global Grand Round series entitled Global Minds, Local Insights. You can hear. Let me see. Good. Okay. We're continuing our Grand Round series, Global Minds, Local Insights, with our honored guest today joining us from Monrovia, Liberia. Dr. Benjamin Harris is the professor of psychiatry and chair of the Department of Psychiatry at A.M. Dogliotti School of Medicine, University of Liberia. Just making sure we're recording so we can share this in the future. He is also an adjunct professor of psychiatry at the Icahn School of Medicine at Mount Sinai and the immediate past president of the Liberia College of Physicians and Surgeons. He currently serves as a consultant psychiatrist as well to the John F. Kennedy Medical Center in Liberia and is an active mentor to medical students, residents, and interns throughout his career, and has been a researcher and conducted a number of studies in Liberia. He's a clinician and educator with a vast experience in post-conflict mental health. His primary areas of expertise are psychoactive substance use prevention, HIV/AIDS related mental health, and general health, mental health policy, program planning and implementation and supervision. Dr. Harris worked for a number of years with the Global Program on AIDS and played an active role in the development of the WHO's HIV and AIDS related counseling policies and guidelines. Dr. Harris is also the only Liberian psychiatrist for a number of years and has been essential and crucial in the development of postgraduate education in psychiatry in Liberia, where they now have from one psychiatrist to soon, later this year, by next year, potentially up to 9 psychiatrists, having graduated local Liberian psychiatrists who are changing the mental health system. It's my pleasure to welcome Dr. Harris.
Thank you very much for this beautiful introduction. And thanks to Dr. Henderson and his team for inviting me to Boston to speak to you about the development of our mental health psychiatry residency program in Liberia. And I'll also be talking to you about the development of our first mental health policy. Okay. This is a brief outline. I'll talk first about Liberia's demographic and socioeconomic profile at 2008, and I chose 2008 because that's just a year before the development of our first mental health policy. Give you a brief overview of what mental health in Liberia was like at the time, and then how we developed the policy. And then I'll talk briefly about the residency training program. So the first thing I'd like to talk about is to give an idea of where Liberia is. Liberia is a small country. It's about 43,000 square miles, and it's situated on the west coast of Africa. This is Liberia, and it borders Sierra Leone. That's Sierra Leone, and that's the Republic of Guinea, and that's the Ivory Coast, or because it's a French-speaking African country, is referred to as La Côte d'Ivoire. See, we have a rather long seacoast in Liberia. Now, the country was founded in 1847, and how it was founded is an interesting one. In the early 1800s, a group of freed slaves decided they wanted to go back to make a home in Africa. There were some philanthropists at the time who decided to support this dream. There were also others who probably had the view that it was better to get rid of the freed Black slaves in the first place. But they put the funding together. They called themselves the American Colonization Society. And the first ship load of individuals, about 80 something, the ship was called Elizabeth, sailed across the Atlantic and went to this part of Africa. They landed in an area called Chevreau Island first, that was around Sierra Leone. And they found out that was a British area, and they moved further west and landed at the Providence Island in Monrovia. The country went through a catastrophic period from about 1980 to 2003. 1980, we had a devastating coup d'etat where the president of the republic at the time was assassinated, and 13 of his government officials were brutally killed on the beach of the Atlantic Ocean. They were tied to poles, and they were all shot. And then the bloody civil war emanated in 1989, December, just before Christmas. The news broke that insurgents had entered an area of Liberia called Nimba County. And this war lasted until 2003. So it's a long, traumatic, and disastrous period. In 2008, just a year before we embarked upon the development of the mental health policy, the population at the time, post-war population, was 3.249, about 3.5 million. And over 50% of the population was less than 20 years old. We had only about 3% over 65. The life expectancy was low, only about 41 years at the time. And the annual GDP had dropped by 80% from the 1980 coup d'etat period GDP. Now, in about 2008, there was a donor conference that was being established in the States, supported by the World Bank. And this was mainly to support the development of basic healthcare services in Liberia. And someone informed me that this document had nothing to do with mental health. So I went to the office of the minister at the time, and I said, Mr. Minister, I understand you're presenting a document at the donors conference about developing the basic health services in Liberia, and there's nothing about mental health. And then he realized that this was a great omission, and this was included. You'll see on the right side, there's the 2019 data, and the population 2019 was 4.9 million. And I use 2019 because that was the year we embarked upon the residency training program. The per capita GDP had increased somewhat, 530. This time it's about, I think last year was reported at about $750, which is still quite low. So until the 1960s, there were no formalized mental health care services in Liberia. What existed was that health institutions, traditional healers, tended to provide mental health services. And management focused mainly on individuals who had psychotic illnesses and other serious mental illnesses. And cases like anxiety, depression, and so forth were not identified nor treated. The treatment at the time tended to be quite harsh and often inhumane. In the early 60s, about 1961, 62, a group of concerned women decided that they would establish a psychiatric facility. This group was headed by the wife of the president at that time, William V.S. Tubman. And one of our colleagues, a member of this group, donated 90 acres of land, provided that if the hospital was erected, they'll name it after her mother, Catherine Mills. So this institution was established in 1963 and was called the Catherine Mills Rehabilitation Hospital. 30 acres of this 90 acres were fenced in, and the psychiatric facility was constructed. When I returned to Liberia, after a couple of years, I became the medical director of that institution. But then when the war started, this facility was completely destroyed. And most of that land has now been taken over by various groups of people. This is what the main hospital complex of the Catherine Mills Rehabilitation Center looks like now. This used to be a beautiful facility. In fact, we had a number of facilities on these grounds. We had the general mental health facility. We had doctors' quarters, doctors' housing, nursing, students' housing. We had long stay units, short stay units, and step-down units at Catherine Mills. Small cottages where individuals were about to be discharged were transferred to these brick cottages that were constructed by donation from Firestone Plantation. They have a huge rubber plantation in Liberia, and they erected these cottages. And patients will be transferred there, and their relatives at times will come during the weekends and spend some time with them. But at the time, although this facility was well funded, treatment was centralized. People had to come from all over the country to Catherine Mills. There were no clinics in any of the peripheral hospitals. And so these were limitations that we suffered. In fact, I remember that on a few occasions, aggressive and violent patients were brought down in logs. And at one time, we had to saw off the logs of somebody's leg because the leg had become so swollen and gangrenous that they had to be transferred to JFK for amputation. Then the conflict in 1989, December, started, and it wreaked havoc on the population. It's estimated that there were about 250,000 individuals who were either killed or seriously injured. And the entire fabric of the society was devastated and destroyed, including the health sector, and as you saw, even the mental hospital. In fact, many of the mental patients were shot when the rebel forces entered that area because they thought that they were government combatants feigning mental illness, and so they were executed. Now, during the war years, little or no health services were offered throughout the country, and mental health services were not available at all. About 25 to 75% of the combatants during these 14, 15 years of civil conflict were young children. Schools were usually closed. I did a study in 1994, which showed that 60% of the students, or 60% of young people had witnessed someone being killed or tortured. 70% reported having lost confidence in humanity, and 80% have reported having lost a close friend or relative during the war. Post-conflict, there was a high incidence of trauma-related mental health problems. 40%, according to a study that was done by Kirsten Johnson, 40% met the diagnostic criteria for major depressive disorder, and 43% for PTSD. This was a household survey of about 1,600 persons. In 95, I also did a study, a rape study in a number of shelters in and around Monrovia. And my study showed that 33% of the women in these shelters had been sexually molested or raped, and weapons were used in 86% of cases. There was another study in 2004 which showed a much higher rate of rape in 2004. And this is a lady that was referred to me by UNICEF. UNICEF is the United Nations Children and Educational Fund. And she was seen by some workers in UNICEF and sent to me because she had serious mental health problems. And she told me that she was 9 months pregnant when the fighters arrived in the village. They grabbed her and her husband and tied them up and tabed her. That's a type of technique where they tied your hands behind your back and pulled it until your ribs separated from the sternum or the ribs fractured. And she said she was raped by about 15 young men. And she said a day later she delivered, and of course, the consequence was that she had the problem with her uterus not being able to remain in place. People suffered quite a lot. There were many rebel forces, and when one rebel group started, it broke up into various segments and fought against themselves. So even the main rebel group, NPFL, they split up in the INPFL and started fighting amongst themselves, and the NPFL, they started fighting amongst themselves. And then you had ULIMO K and ULIMO J that broke apart, and they started fighting the government forces and themselves. So we decided that it was time that we begin to look at the development of a mental health program. And the first thing that we thought was most important was that we develop a policy to base our planning on, that will start from a foundation that will lead us to an informed decision-making process as we go forward. And as I said, the need was paramount. The war was brutal. There were severe physical, social, and economic mental health consequences. And most of the country had been displaced internally or externally at some time during the conflict. And as I said yesterday, I was displaced too at one time. My family had to leave the country, and they're still out of the country in the United States. So the policy was a result of a comprehensive series of consultative meetings. A number of committees were formed, and key national and international stakeholders were brought to the table. Adverts were put out for individuals who would lead the development of the policy. And we had a number of international organizations and institutions that applied. And I'm pleased to say that a young man headed the team from Mass General and Harvard University, and that group was selected and went to Liberia. I served as the WHO country consultant on this project. And I see Dr. Marjorie Stone, she played a major role also in the development of this policy. So we developed consultative workshops to plan this process. And one of the first things that the lead external consultant thought it expedient to do was to do a needs assessment, a quantitative key stakeholders need assessment of the mental health needs of children and adolescents in Liberia. And this further informed the policy. After the draft policy was developed, a validation workshop was held. And we had the vision and the mission of this policy. And it was based on the WHO's optimal mix of services using all strata of service provision, from self-care to informal community care to more formal specialized care. Now, if you look at these aspects of the policy foundation, you'll see training of health workers at all levels. Now, this may seem simple and obvious, but even that was difficult to include in the policy, because there were many who thought that coming from a post-conflict country with a myriad of needs, why should we start thinking about training medical doctors and training specialists when the resources could be better focused on training basic health workers to render care? And there were a number of heated arguments, but finally it was decided that yes, we should train at all levels of care. Now, there is another development was occurring that synced with the development of the first residency training program in Liberia. And this was the establishment of the first postgraduate medical training program in 2013. This institution was called the Liberia College of Physicians and Surgeons. And we launched it in September of 2013. We started with 4 core faculties: internal medicine, pediatrics, general surgery, and obstetrics and gynecology. At that time in Liberia in 2012, there were only 215 doctors serving a population about 4.5 million persons. There were only 144 doctors in the country, and WHO has recommended that there should be 1 doctor per 1,000 population. And we had 144 doctors for about 4.5 million persons, and only 15 specialists in the country. And I was the only psychiatrist for a number of years. So the first group of residents were 19. 16 were Liberians and 3 were foreigners. We had to import 90% of the faculty because we didn't have faculty in Liberia to train the new residents. The second cohort, there were 19 medical doctors and all Liberians. A lot of, most of these young people that you see on the right side of the screen are now specialists in the various areas of those first 4 specializations. Now, the college is divided into, as I said, the College of Physicians and the College of Surgeons. And we have the executive board of the college. The executive board is headed by a president and 2 vice presidents. If the president is a physician, and when I say physician, I mean a non-surgeon, then the vice president, the first vice president, is in a surgical specialty, and the second vice president, a medical specialty. And in this case, the president was a pediatrician, the first vice president, a surgeon, and I was the second vice president. So then you had the Secretary General, who ran the Secretariat, and the honorary treasurer. And an important development occurred in 2016. We received support from Boston to support a psychiatrist from Nigeria to come and join me at the medical school. And this is Dr. Babawale Ojidiran, and he's still with me in Liberia and is assisting me with the postgraduate program. In 2017, we added we had the first cohort of graduates in 2017. But 2017, we added another faculty, and that was the Faculty of Family Medicine. 2018, we were able to secure funding through the Lions Club's International Foundation. I'm a member of the Lions Club, and they deal with, they focus on the blind and visually impaired. And we've been able to get about $1 million from them to establish a postgraduate faculty in ophthalmology. And I served as the grant administrator for that grant to establish the ophthalmology program in collaboration with an Indian institution called the L.V. Prasad Institute. And that facility now is one of the best facilities you can find in any part of the world. There are people who have visited that facility and have told me, I've come from the States, and whatever they've done to me in the States is the same thing that I went through here with the minimum of cost. Even my brother, when he visited me, he went to that facility and was quite impressed. But in 2019, we were instrumental in getting psychiatry added to the postgraduate training program. We had set up a center of excellence in psychiatry with the University of Liberia. And the year before, a team from Boston headed by Dr. Henderson had gone to Monrovia, and an MOU had been signed with the University of Liberia and with the Liberia College of Physicians and Surgeons to establish the postgraduate program. Now, what steps did we take and how did we get to this stage? We established this twinning relationship. We had a partner that was very passionate about global psychiatry and twinning with us. Our approach to developing this program was based on a tried and tested evidence-based practice of building capacity by forming partnerships between academic institutions or organizations in high-income countries and similar organizations in low-income countries. And we were fortunate, as I said, in having a partnership with Boston Medical Center, Boston University, headed by Dr. Henderson. I must say, without him, this would not this would have not been possible. This is a dream come true. This was steadfast in forming this twinning relationship. This is the launch of the first postgraduate training program in psychiatry in 2019. These two, Dr. Limas and Dr. Zia, were our first two residents in psychiatry. This was the first year. Dr. Zia graduated 2 years ago, and now he's been appointed in a position at the Ministry of Health as the National Mental Health Director, or Director of Mental Health Programs in Liberia. Unfortunately, Dr. Limas, just before she sat for her final exams, unfortunately passed. She had developed breast cancer, and although she was operated on, this had spread, and this culminated in her death. And it was very shocking for all of us. Now, this picture, we have a very small but close college. So on some weekends, the residents will come to my house and we'll have Liberian food, okay? In West Africa, we call that meal swallow. For those of you who know, there's somebody in the back, okay? Fufu and some soup or sauce, okay? So this is Dr. Zia Limas, the two second year at that time, and the two first year. In fact, these two year and Dr. Zia have all now graduated. Dr. Harris, my namesake, and Dr. Diggs graduated last year. So the program was structured after the West African College of Physicians with similar curriculum. We have the membership, it goes for 3 years, and then the fellowship, one has to go through for further 2 years, and one has to do a research project which culminates in the development of a dissertation. Our curriculum integrates child and adolescent psychiatry, along with a strong adult and community health program. It emphasizes also a strong research-driven trimming program. And we've collaborated on a number of studies with the Boston team, which these studies have been published. The training is primarily undertaken at the Grant Mental Hospital in Liberia, which incidentally is a private institution that the John F. Kennedy Medical Center pays an annual rent for. So if any of you know someone with a lot of money and wants to donate to building a small psychiatric facility for us in Monrovia, we'll be most happy. So think about that. So we have international partnership, but also intra-continental partnership. We partnership locally with the Step Down unit. This is a unit that is run by a Catholic-based organization in Spain, and it's called Sisters Hospitales. It's a well-equipped, well-functioning psychiatric facility that caters to women primarily as inpatients, but also to see men and sometimes children on an outpatient basis. Our residents also go to Ibadan at the University College Hospital, and that's also supported by the Boston team. We also have a collaboration with the University of KwaZulu-Natal in South Africa at the Nelson Mandela School of Medicine. So residents go to Nigeria for about 3 months every year, and they rotate and gain theoretical and clinical training in psychogeriatrics, addiction psychiatry, forensic psychiatry, and child and adolescent psychiatry. Our Boston team also provides regular seminars, lectures to our residents in various areas that we have deficiency locally in Monrovia. They've supported us by providing an ECT machine and also an EEG machine. In fact, during my meeting with Dr. Unger this morning, he asked me, by the way, do you have an ECT machine in Liberia? And I said, yes. And he said, brilliant. So we're pleased about that. And regular assessments are done by the, in collaboration with the Boston team to ensure that things are going well. Our residents sit for the Liberian exams, but they also aspire to sit for the West African exams. But before sitting for the West African exams, we have to be qualified, have to be accredited by them. We have 3 residents who have received the membership within LCPS, and the 2nd and 3rd year residents have all sat for and passed the primary of the West African College. You can sit for the primary of the West African College without your institution being certified, but to sit for the membership and fellowship, your facility has to be certified. Now, an interesting thing happened in 2022 when we had our first graduate, Dr. Zia. I think you recognize this young man in the back. Yes. Dr. Henderson was honored with our first conferral of honorary fellowship because of the great support he's rendered to us since the establishment of our college. And he was given a certificate of outstanding award by the college. This is Dr. Zia receiving his certificate from me, and this is Dr. Henderson also receiving his certificate from me. And he's been gowned and giving few remarks. This was a day after the formal graduation ceremonies, and this was during the break of one of the scientific sessions. This is last year, where you see Dr. Harris and Dr. Dix receiving their certificate from me. So external accreditation. As I said, before our residents sit for the West African College, we have to be accredited. So with support again from the Boston team, we had a group of assessors, 3 persons, visit Monrovia in March of this year to assess our training facilities. They visited the Grant Mental Hospital, John F. K. Benedict Many, and Médecins Sans Frontières. Our residents also rotate through community-based facilities managed by the Médecins Sans Frontières of France. In mid-May, we received a notice from, and this is a notice from the West African College, saying that we've been given temporary provisional accreditation to run training with the membership and the fellowship for the next 2 years. And after 2 years, they will be visiting us again after their annual meeting, they will finalize their report, and that report will indicate those steps we will have to take to gain full accreditation. And these members of the team, this is 1, this is 2, and this is 3 from the West African College. And this is the Grant Mental Hospital where we train. So what are our accomplishments? So we've made some significant strides. And it's primarily due to this collaboration. The passion, commitment, and perseverance has constituted this relationship. It is further strengthened by the continued interest in this collaboration. We have regular monthly administrative meetings to discuss challenges and accomplishments in the program, the progress of the program. And even yesterday, we had one of our Zoom meetings. This time, I was a part of the Boston team in the meeting. So we now have 3 psychiatrists fully trained in the country. 2 more are sitting the examinations next week. And we anticipate that they both will pass because they're very smart young people. We've developed the mental health policy, and now it's been revised twice. So we have the 3rd update in the mental health policy. And now, for the first time in Liberia, we have a division of mental health. And with that division, we're looking forward to a budget for the first time being included for mental health services. We have a fully functioning postgraduate program and improved services, greater awareness in the community about mental health. And needs of the people are being met when before this was not available. We are developing a database of publications that have been directly emanated from this collaboration. This is the facility that we utilize now as our training facility. And I put this as last to remind you that it's rented. And it's small, it's inadequate. And even the assessors, they kept asking us, when are you all moving from this facility? We suffer from inadequate availability of drugs. Sometimes we have a good range of drugs, and sometimes we're short on drugs. The step-down unit that I mentioned previously has a very good range of drugs, and the drug supply is always constant. And so they sometimes assist by providing medications to the Grant Hospital. We're also facing some difficulties in getting new recruits into the program. For the next year, we have 1, and this will be the first time we've had only 1. Hopefully, we'll get another in 6 months. It's because when you finish medical school in Liberia, you have to do your internship. After your internship, you have to do a government-prescribed 6 months training to improve your surgical skills, gynecological skills, and general surgical skills before you can do anything else. And once in the past, we were able to get an exemption from someone. If we're able to get an exemption, then we'll have another person joining the program before the start in September. If not, we may get another person early next year. So that's all I'd like to talk to you about. Thank you very much for listening, for your attention.
we have some time for questions. And before we do that, I do want to recognize there are some people in the room who have contributed to the Liberia didactics, the didactic planning, as well as having help with program assessment. So if those of you who've contributed for Dr. Harris to see, could you raise your hands or stand up just to share that you've been a part of that?
Thank you. Thank you, all of you. Thank you very much. You've been a great help.
Or if those of you, I think there might be some people online too. Let's see. Okay, so we can go ahead if there are questions. Go ahead and ask if you're online. Please, if you can unmute and open up your camera as well to share with the rest of us.
I wanted to know I guess since I'm a resident, maybe for a resident, what would a typical day look like?
I'm sorry, I'm not.
For a resident, what would a typical day look like? Like how many patients are they seeing? Because I'm imagining there's so few psychiatrists and so many patients. I'm just wondering like how many patients are they seeing? Yeah, what does the workflow like?
First of all, let's talk about inpatients. The hospital facility was built for about 40 patients. And now we have on average, about 80 patients. So that's the first thing. And the patient load on an outpatient daily day, one doctor sees about 50 or so patients a day. So it's a very busy facility.
Well, thank you so much for sharing with us. I feel very privileged.
I'm sorry, you have to speak in
Thank you for sharing with us. I feel very privileged to be able to watch, and I'm from Nigeria, so I felt very connected as you were sharing. I do have a question about the clinical interventions and what the residents are primarily using and trained in. I'm also curious about what other mental health.
I'm sorry, let me.
I'm also curious about what other mental health care workers are part of your team or what that looks
like. Oh,
like.
other mental health workers.
Yeah, and then the other clinical interventions are like the residents being trained in. Or like
Okay. Now we have occupational therapy. A therapist that's there who helps with occupational therapy. We have mental health social workers. We have a number of trained clinicians, mental health clinicians, who were trained by the Carter Center. So the Carter Center trained, I think, over 300 or so mental health clinicians, and we have a number of them there at the facility. We have, not regularly, but intermittently, we have psychologists that come in to assist us. We also have intermittently neurologists who visit, a neurologist who visits our center. And these are neurologists that are posted to NGO facilities, and they come and offer assistance when we need to. We have group sessions, so we offer group therapy to our patients also.
Thank you.
Ben, thank you so much. So I remember years ago, back in the establishment of the Center of Excellence, there was actually a talk about establishing PhD programs for psychologists.
That's right.
Did anyone ever get to that, or is that still in the plans? I say this because we have a lot of psychologists, and we have this longstanding multicultural psychology program here. So
this is something that is much needed. As I said, the psychologists that we get tend to be intermittent, And the university has, and is still talking about a psychology program. And this is something that probably we should discuss more seriously and begin to plan about it, because it's something that's quite doable. Yes, I remember quite well that we had discussed this some years back. Yes. Okay.
Well, in the recent, well, the previous year, I know that Johns Hopkins University was having conversations with the university on setting up the PhD program, helping them to set up a PhD program, and they were having conversations about which specialties they focus on first. And so the primary one was actually PRPH, to do a doctorate degree at the University of Liberia. So currently, they have somebody from Hopkins in Liberia having conversations with the university about further developing this PhD program. Now, which specialty we focus on initially is not clear, so they're still working out the modalities. As far as I know.
Yes, I know that there have been a number of institutions, including Yale, that has been partnering with the College of Health Sciences in developing their programs. And they've started the nursing program within the university, but the psychology program is still under discussion.
In terms of recruitment for the residency program, louder? Okay. In terms of recruitment for the residency program, are there efforts at the medical school level to showcase how amazing psychiatry is, or how are you attempting to recruit the next cohorts?
Okay. I teach medical students also, and Dr. Jideran does that also. So each class that comes in, we ask them about their interests and try to stimulate them and direct them in psychiatry. So that's what we try to do, and it's paid off because at the beginning we didn't expect that we would have 2 in the first year, 2 in the second year, and 2 in the third year. But we
Hi, Doctor. Thank you so much. Can you hear me all right? Thank you so much for your presentation and for your steadfastness and commitment. It was very beautiful to also see you point out the people that have been part of this journey and making it come about meaningful. So thank you. I have a question that's also building upon your presentation yesterday, if that's okay. Dr. Crawford had asked a question about children, and you provided like a very helpful, comprehensive background to the context you're working from. And I'm wondering about, when you were sharing the triangle that you've taken from the World Health Organization in terms of self-care and then informal community care as a means to also help there's such a burden placed on you all. And I'm wondering, what kind of interventions are used, given that so many of those involved in the direct violence were children themselves and their own childhood taken from them. And later on, that can also contribute to more severe mental illness and societal burden. And I'm wondering, I understand that it's more difficult now to live with children, but have you seen things that maybe at the informal community level, folks are bringing in and trying to do some of that work together?
At the moment, what we're doing at the postgraduate program, we have formed a collaboration, as I said, with community health centers run by NGOs. Our residents go there, work in the clinics, also do community outreach. And during that outreach, various communities, we talk about mental health problems affecting children and adults, and try to identify individuals with problems in the communities. These individuals are encouraged to attend the clinics. And with the NGO facility, it's completely free. They don't have to pay for anything. If individuals, adults, need inpatient admission, then they're sent to the Grand Hospital or the step-down unit. The step-down unit does similar things. The residents rotate there also. They have a very good community-based program. In fact, with them, they go out of Monrovia. They go throughout the country. In fact, the last time they went to a place in Lofa County during the rainy season, the roads were so bad, they even with a four-wheel drive, they got stuck in the mud. And now we're beginning to see patients at the step down from Lofa County who are coming in because of mental health issues being referred from there. One thing that was in the mental health policy and plan that's not being I guess optimally carried out is that we had envisaged setting up wellness unit, mental health wellness units in the various counties in the country so that individuals will not have to leave from the interior to come to Monrovia. And some of these wellness units were established. But because government salaries are so low and other challenges, these clinicians, trained mental health clinicians who are assigned there tend to get other jobs to be able to make more money. And these wellness units cease to be functional after a while. So now with the development of the mental health unit at the Ministry of Health, hopefully some more focus will be placed on these wellness unit to be able to provide services.
So much. We're at time. Thank you so much, Dr. Harris. This was really, really wonderful. I also see we have at least one of the librarian residents on the call, actually, who's graduated. Dr. Diggs is on the call now, but thank you, everyone. And our final event of this series is in 2 weeks, where we have Dr. Leila Asmal coming from South Africa to join us. So thank you.
Thank you for coming, Dr. Harris.
Yes, I don't know if you remember, but I gave you the 20 okay. And I